Well, hello everybody, and welcome to session number 4. This is Patient Safety in NCD Management. I am Helen Haskell. I'm chair of the WPA Patient Safety and Quality Council. I'm so sorry that I can't be there in person with you today. I'm an American patient safety advocate and longtime former chair with Hussein of Patients for Patient Safety at WHO. Our session today is focused on the WHO Global Patient Safety Action Plan and the role of patient safety in treating patients with NCDs. So of all the topics we're covering this weekend, I think this one is the most important. As Dr. Tedros, the Director General of WHO, has said, there is no point in having universal access to health care if your health care is not safe. And the fact is that healthcare has safety issues in every country in the world. It's what's called a wicked problem. Wicked, complicated, and difficult to solve. And patient safety is especially problematic for patients with NCDs or chronic conditions because their problems tend to be more complex, more difficult to interpret, and involve more interactions with the healthcare system. Our speaker is Nikhil Gupta, longtime technical officer at Patient Safety at WHO. Nikhil will also be joining you remotely. I won't go through his entire biography. You can read it here. But Nikhil has had a long and impressive career in patient safety and quality. He was a key figure in developing the Patient Safety Action Plan and the first global patient safety report, which he's going to talk to us about today. We'll follow Nikhil's talk with a panel discussion featuring Christina Delgado of Occupad, Jolanta Balinska of the World Patient Alliance and Polish Patient Safety Foundation, and Luis Lorenzo of the International Pharmaceutical Federation. And Hussein Jaffrey of WPA will be moderating. And with that, I'm going to turn the virtual podium over to Nikhil. Welcome, Nikhil.
Thank you, Helen, for this introduction and initiating the talk. And thank you also to organizers and Dr. Jaffrey, especially for inviting us, WHO, for participating in this important European regional meeting of WPA. As we plan this session, I will be talking about the Global Patient Safety Action Plan in general. What is this plan about and how we are performing right now globally. And that will be followed by the panel discussion. Sorry for my voice. I'm just still recovering from a viral infection, but I will try to be a bit as much clear I can be. So can we move next slide? So as we know, I'm not sharing any new data with you, but the patient safety and poor quality of care is a bigger, very large public health issue. And the estimate shows that more people die because of a poor quality of care than the access itself. And 1 in 10 patients die because of unsafe care globally. And it's not only the health burden, the financial burden is also very huge. 12% of direct healthcare cost is attributed to the safety failures, and which amounts to around more than 1 trillion of the global GDP annually. Looking also into more reputation and health system impact, where 4 in 10 patients with chronic conditions lack trust in their health system, and that creates not only a safety issue but also access issue, because people, if don't have confidence in their system, they won't go to the hospitals. And as we say, second victims, health workers also get impacted by the unsafe care, and they frequently leave the job or report burnouts because of these conditions. Next. So given this huge importance of patient safety globally, The momentum built by many countries and stakeholders, including patient champions. In 2019, the World Health Assembly adopted a resolution, Global Action on Patient Safety, which recognized patient safety as a global health priority. WHO also established a day dedicated to World Patient, that is World Patient Safety Day on 17th of September. And the Assembly also mandated WHO to develop a global patient safety action plan. That's what I'm going to talk about. Next. So the action plan, many of you were part of when we were developing. This action plan was launched in 2021 during the pandemic. Next slide. And this plan has a mission of driving policies, strategies, and action based on science, patient experience, and system design, and partnership to eliminate all sources of avoidable harm to patients and health workers, with the goal of achieving the maximum possible reduction in avoidable harm due to unsafe care globally. Next. So this action plan, it is from 2021 to 2030. So we are in about middle of this action plan implementation. This action plan is arranged or structured in 7 strategic objectives. That starts with strategic objective 1 on policies to eliminate avoidable harm. Then the strategic objective 2 is about high reliability systems. Strategic objective 3 about safety in the clinical processes. Strategic objective 4 on patient and family engagement, where we are focusing on in this workshop. Strategic objective 5 on health worker education and safety. Sixth one is on reporting and learning system information and research. The seventh one, synergy, partnership, and solidarity. I won't go into detail of each of them, but those who are new to this action plan, that I assume should not be the case here, I would suggest to go through the action plan, because for each of these strategic objectives, we have further strategies. Can we move to the next slide? It's a bit busy, but I'm not kind of requesting you to kind of go to the content here. Just for the illustration, for each of these 7 strategic objectives that I just discussed, we have further strategies, 5 strategies for each of the strategic objectives. So what we say 7x5 matrix. And these are expansion of these strategic objectives, how these should be implemented. In the action plan, you can find further the suggested actions for different stakeholders, like for governments, for healthcare facilities, for stakeholders, and also for WHO itself. Next. So this is just in brief the Global Patient Safety Action Plan and what it aspires to achieve. I've been also asked to share how we are progressing. So as we launched the Global Patient Safety Action Plan, which was endorsed by World Health Assembly unanimously by all the member states, then it becomes very much WHO's function to measure that how countries are progressing on the Global Patient Safety Action Plan and the 7 strategic objectives. Next. So the Global Patient Safety Report that is available there, it's quite extensive work, and you can find the data and the discourse on different aspects of patient safety there. In this limited time, I will be just talking about some salient messages that is coming out very, very, very clearly from the report itself. So first of all, how we are progressing on these strategic objectives. These are the cumulative scores. Those are reported in the patient safety report. And you can see there's a variable performance on these 7 strategic objectives. Some of them are comparatively better, like say policies and strategies for patient safety, that is strategic objective 1 and 3, the clinical processes, because of the legacy established program and policies even before this action plan came into the picture. Some of the strategic objectives, like you can see patient and family engagement, or even strategic objective 7, synergies, partnership, and solidarity. You can see the performance is not at par or is not as good as in other strategic objectives. So certainly there is also a scope of reorienting our compass, reorienting our strategy, how we can have good progress and can balance the progress in all the strategic objective. Overall, globally, you can see the progress is around 49%, about midway. By the 2030, we would like to achieve the full implementation of this action plan. So certainly, we have a challenging task from now 2025 and this action plan when it is going to close in 2030 to accelerate our actions. Next. So some of the key messages, those are coming from this report and the feedback that was provided by the member states, the countries. This data is based on 108 countries, those responded. Right now we are analyzing data for the second round of survey, and next year we will be publishing another report. And this time we have a better coverage. Around 154 countries have already, we have received the data. But this is from the previous 2024 report. I'm not sure how big is the screen, so you can read it or not, but I will try to explain. So first of all, where we are, so I can see it's a very much dynamic process in motion. Only less than one third of all the criteria or the strategies where we asked for the actions and the progress have been completed. Most of them, 44%, is very much in work in progress. So it's a good news that lot of work is already going on, but it's also a responsibility that we convert these work in progress into real achievement. And we next time when we review the progress, there should be more proportion of completed actions. Next. The another trend that is very much coming up when it comes to the advocacy or a high level commitment, we see comparatively kind of a better performance, like 55% countries have said that the patient safety is priority for them. But when it really comes to implementing that priority, that advocacy into real programs, the performance is not good. So you can see that only 29% countries have patient safety programs, only 21% provide dedicated budget or adequate financing. Next. Coming to the systems approach, the high reliability system, that is strategic objective 2. You can see again when it comes to more superficial, or I would say the initial kind of actions like appointing a patient safety focal point, still it is 52% countries are saying they have somebody to work on patient safety. But when it comes to more complicated actions like applying human factors or having a safety culture, the performance is not that well. Next. So we also asked about from the countries, which are the areas where you are having focused programs, patient safety improvement programs. And you can see some of the classical domains like surgical care or maternal care, obstetric gynecology, or clinical or intensive care. We have good response. But when it comes to some of the even chronic areas or the areas those are not traditionally very much where we don't have very much established programs, like say geriatric care or eye care, mental health or oral health, we can see the performance is not, some of these are even less than 40% of the compliance. So it's a very clear message, if we want to, and here we are talking about patient safety in NCDs. We have to look into the areas those are under represented, or where we don't have structured programs. We should implement, so we can have a comprehensive patient safety implementation across all the domains and clinical practices. Next. Coming to the patient engagement, again, looking into the patient engagement maturity from information to co-development, we can see there are initial gains where patients should be informed, like say having consent guidelines or access to medical records. There is a better performance, but when it comes really to engage patients in day-to-day service delivery and designing of the system, we asked a tracer indicator about having patients in their hospital governing board. Only 13% countries reported that they have such practice currently in their health system. Next. Looking into the health worker safety, can we go back? Can we go back? Yeah, here. Yeah, next one. So looking into the health worker safety and their education, again, you can see the indicators are not very currently well performing. Only 20% countries have patient safety in their professional education curricula, and only 14% countries have some capacity to provide training on patient safety. Next. When coming to the reporting and learning system and using data for improving patient safety, again, we can see only 1/3 of countries have some kind of a reporting and learning system, and only 11% of them utilize data really to generate learning and alerts from all different sources of safety data. Next. Coming to the strategic objective 7, and finally about the stakeholder engagement and a synergy. Again, we can see there is a very differential kind of a performance, and what kind of stakeholders are engaged, like professional associations. You can see around 71% countries have said they engage, but when it comes to industry, it's only 35%, and for civil society 44%. So this is again the scope of engaging all the stakeholders to really achieve the targets of this action plan. Next. Some other kind of data points or impressions from the report. Again, these are all charts from the report. We also asked about the public health programs, including the non-communicable disease, whether you have a patient safety initiative implemented or integrated in those national public health programs. And you can see some of the traditional areas where there's already been existing quite a good work on patient safety, like maternal health and child health and HIV/AIDS. You can see the performance is comparatively better. But when it comes to, say, non-communicable diseases, you can see it is less than 50%. Next. Also zooming into the patient engagement, patient and family engagement strategic objective 4, you can see this is the global barometer or speedometer, where you can see the overall progress is about 45%, but when it comes to, say, patient advocates and creating patient safety champions, it's only 34%. It's doing better on, say, consent management or incident reporting and disclosures is 55%. So again, there's a variable kind of a performance in different 5 strategies of the strategic objective 4 on patient and family engagement. Next. Looking into regional performance also, this is again for the patient and family engagement strategic objective 4. And you can see on the x-axis there are these five strategies, and then horizontally you have 6 regions of the world, the WHO 6 global regions, and you can see some of the regions like Afro and Southeast Asia region. You can see, so the red one means the performance is less than 4 out of 10, and 4 to 7, the yellow one are progressing, and the green one is advanced. So you can see there is no green here. So none of these 5 strategies across 6 all regions, none of them have reported the performance of our advanced level. Most of them are red or yellow. So certainly there is this much work to be done for patient and family engagement for all 5 aspects. Those are written in the Global Patient Safety Action Plan. Next. So I will conclude here. This was just a snapshot of the action plan and some of the relevant areas where that could be of interest of the audience and the participants here. But I will really encourage you, to those who are working in this area, to go through the Global Patient Safety Action Plan as well as the global report, because if we know what are the specific action those has to be implemented, certainly it will help us in accelerating the actions for this agenda. Thank you so much, and I will give back the dais to Helen. Thank you.
Thank you, Nikhil, for that informative, high-level view of global patient safety. I am now going to turn the microphone back over to Hussein, who's going to lead our panel discussion. Take it away, Hussein.
Thank you, Helen. Thank you very much. So we'll have the panel discussion, and I'll request the panelists to come on to the stage. So the first one is Cristina Padoma Delgado. She is the Coordinator, Research Department, CUFADE. Jolanta Bilinska, she is the Chair of the Patient Safety Foundation as well as Director of World Patient Alliance. Luis Miguel Lorenzo is the Professional Secretary, International Pharmaceutical Federation. So let me start. So I'll start, Dr. Nikhil, with you. Thank you for an excellent presentation. It was very, very interesting. And I just wanted to ask, so there were some certain areas where no progress has been made, as you said, 26% of the whole work where no progress has been made. So what is the percentage of strategic objective 4 in that 26%? Is this, by and large, the patient engagement part that's missing, or it's kind of uneven, or maybe it's lacking in all the regions. So you showed a slide where you showed the progress. 26% of the work was not even initiated in certain areas. So I'm just asking, what is the percentage of patient objective of 4 in that 26%? Do you know?
So as we can see that the individual scores are like for the patient engagement, this is 45%. So 45% constitute of completed work in progress and non-initiated. And I can dig out the specific percentage, but I can assure it is less than 26%, because the non-initiated area, that is very much evident from all those blue dots you were looking at in the traffic lights. So most of the regions for the strategies related to patient engagement, these were red. That means the score was less than 4. So certainly, if you ask me, to this not initiated 26%, all 7 strategic objectives have equal weightage, but the effect of strategic objective 4 certainly will be higher and is higher than others. Looking also into the core indicators, we have these 10 core indicators that I haven't discussed here. The least performing indicator was on the patient engagement only, where only 13% countries reported to have some system or mechanism of involving patient champions or patient representative in the hospital governance. So there is a scope of improving everywhere. But if you ask me, patient engagement, strategic objective here, the situation is comparatively much more acute than others.
All right. So Dr. Nikhil, what is your experience of, are we truly listening to patients? And when designing, safety solution, are we listening to patients as well, or is still the system, the ministries, the department, they are the ones who are just making those decisions, especially when we are collecting feedback, are we really listening to them? And what should it take to make patient voices an integral core decision-making part of the safety systems?
I can contribute my reflection, and I think the eminent experts and really the patient champions, those are sitting there in the meeting in person, may have much more profound understanding of how it should work. I'm just reflecting in data and some of the understanding that is coming again from experts and patient champions like you. Very much that is evident, at least from data, that still there is a lot of scope from moving from kind of engaging patients as tokenism to really having a meaningful engagement. And that is very much, as you see, the indicators like having feedback or consent are still better, but when it comes really or giving information to the patient, those are comparatively better. But the indicators like I discussed about having patients in the hospital governance or even policies and strategies, uh, those are not very well performing. So I would say that right now the approach predominantly is more reactive, where we are engaging patients only when there is that also is not 100%, but at least relatively it is better when there is an incident happening, you are engaging patient, or when you are going to them for a feedback. That's a good, I would say, primer. But if we have to really want to kind of embed this in a systems approach and having patient as really the co-producers of healthcare, we have to look into more integrative approaches where patients should be part of not only these reactive or incidental kind of engagement, but more into day-to-day delivery as well as design of the healthcare system. And the Global Patient Safety Action Plan very much provides many of the strategies and actions how we can do that. So, like having patients or their representative in the groups and expert groups where these policies guidelines are designed at the national subnational level, as well as having patient representative in the hospital governing board, and also as an educator, as part of their quality improvement or safety programs. So that could really, it's easy to say, it's really a complex process. It will require a lot of advocacy and as well as political will. But I see that even if we have that, if we don't have capacity within our patient organizations or those who want to work or represent patients, it's not going to. So it's not going to happen. So certainly we have to do this all high level advocacy to engage patients, but also we have to build more from the supply side. I would say supply side means having more trained and skilled patient champions, both improving their competence, those who are already there, but also to widen our cohort to have more patient champions. Still, in many of the countries, it's very difficult to find a patient educator or a patient champion that can really trigger the action in that country. So certainly, there's plenty of work required, and many of these activities could be very much supported and can be led by organizations like World Patient Alliance better than governments and WHO.
Okay, thank you. So before moving on to our panelists, I have one more question for you. And that's so as patient safety in NCD is gaining traction. How can we leverage insights and best practices from domains where patient safety is well embedded to accelerate progress and ensure safe care for people living with chronic conditions?
So that's very, even if you recall that graph I showed you, that where patient safety in NCD, still it is not as a recognized area like in other acute care programs like say surgical care or maternal and child health. Because of course, the obvious reasons, because in those areas we have established programs and NCDs still we are having this discourse. That's good that we are now talking about this. But if we have to accelerate action, first of all, we can also learn from these acute care patient safety programs. We can learn from safe surgery initiatives of WHO or medication safety or safety in maternal child health. If we want to have the same kind of a program in NCD settings, chronic care, certainly we have to have a framework. We have to have focused strategies and implementation actions. And we can learn from acute care program, but the NCD, because of the chronic care, the chronic condition unfolds in over the years. So we have to look into some of the aspects those are very peculiar to NCD. And some of the areas where WHO works could be much more relevant to NCDs, like patient safety in primary care, about the diagnostic safety and the safety of medication itself, because for the chronic care, many of these medicine has to be taken by patient in their home, in their more self-care setting. So certainly we can learn from programs where we have already quite a good established systems, but we have to also think and reflect and strategize how these can be adopted or adapted for non-communicable disease or chronic care programs. Thank you. Over.
So thank you, Dr. Nikhil. So now I move on to Yolanta. Tell us about your experience as a patient advocate. What do you think, from your experience, what are the most common safety concerns faced by the patients, as far as, the chronic conditions are concerned?
Especially the most concern issue is that it is not a coordination between providers. I think it is very bad if the patient is, for example, diabetic, cardiovascular, cancer. They need to go to different specialists. It is not one like cardiologist or neurologist. They are going to many specialists. And what happens? They received different information, different prescription. And there is no coordination how to treat the patient in a holistic way. They just received some medicine from cardiologists, some medicine from neurologists. And what happens? They eat more than 5 to 7, what is a safe amount of medicine. They eat sometimes, even in my hospital in which I work, 30 tablets a day with supplements. So this is a very miserable situation because some results are lost in this process, and sometimes patient repeatedly has examination which is unnecessary, and even sometimes diagnostic is not coordinated. So I think it is very dangerous and is not in the way to give the safety to the patients. Another thing, it is that sometimes this not integrated care of patients made that patients is feels still not well protected, not on the best way to stop this disease, or to make even better for the patient. Other thing is that patients sometimes didn't have enough information about the disease. And this is also a problem, because then it's not adherence and not compliance what doctor advise. So I think these are two crucial things which we should avoid. So this fragmented care is not proper for the patient.
Thank you. So now my question is to Christina. So how can we strengthen patient safety practices in our associations to ensure appropriate and risk-free care for people with different patients, or in your case, people with Alzheimer's disease who live with, non-communicable diseases such as diabetes and hypertension?
To ensure proper and risk-free for people with Alzheimer, we can present patient safety. What is this? Now. Practice through comprehensive care protocol, establish clear guidelines that address both the management of Alzheimer and non-communicable diseases, continuous staff training, educate caregiver and healthcare professional on safe medication management for prevention, other risk reduction strategies, effective communication, implement standardized communication system among doctor, nurses, family member, and caregiver to prevent medication error or duplicate tests, monitoring and evaluation of incidents, record and analyze advanced events to identify patterns and continuously improve patient safety.
Thank you. So now to Luis, one of our partners, the pharmacists. So from your point of view, what are the major changes to improve patient safety in NCD management?
Well, thank you for the question, and thank you for the kind invitation. If I may, just for a minute, just to introduce FIP's Global Federation of Pharmacists, healthcare professionals working in different areas of practice, in community, in hospitals, in drug information centers. And actually, this is a very timely discussion because next week we'll celebrate Worldwide Medication Safety Week. Since 2016, FIP has been an active partner on this event. So I think it's very timely to discuss this in this panel. When it comes to the challenges about NCDs patients and actually you can improve their safety, I think I'll just cover three major points related with pharmacy practice. First, and that has been covered beforehand, the dispensing part. We do take a lot of time and effort to dispense the right medicines to the right patient, to give the proper counseling. And I think it's worthwhile to emphasize the fact that's important to make it more robust in a way that incentivize the work of pharmacists on this time of dispensing, to help patients how to know how to use their medicines, how to understand what they are for, how to include the medicine in their pathway, in their journey, in their daily life, what needs to be adapted. So all of this takes time. So I think it's relevant to emphasize the role of pharmacists at the time of dispensing. The second part I'd like to cover is related with the fact that has also been mentioned here, that most of NCDs actually take a lot of medicines. They have comorbidities, they have different conditions, they do interact with a lot of prescriptors or prescribers, they interact with a lot of healthcare professionals, and it's important to emphasize that it is actually a good practice to have medication reviews. And what's that? Just to allow not only a pharmacist or a qualified healthcare professional to go through your medical records and to spot issues that might be related with our medications. Are there any duplications? Are there any side events that in a way are trying to be compensated by other medicines? How can we improve a certain medicine? How can actually, shall we throw it? We have been discussing quite a bit de-prescribing, because we know that patients, when they go to 10 plus medicines, sometimes actually it's worthwhile to de-prescribe some of those medicines. And the third part is related with the fact that NCD patients often actually go to different points of care in a way that they can go to community, they can be admitted on the hospital, they can undergo a surgery. So when you actually have this change of level of care from primary health care to secondary care or even to tertiary health care, it's important to make a medication reconciliation. What's that? To adapt your medicines to the condition where you are. Just to have an overview or an idea. If you have a medicine, for instance, that is metabolized on your kidney, if you undergo a surgery, your kidney will be impaired because you lose some blood. So it is advisable in these conditions to go through a medication reconciliation and switch that medicine to another one who has similar effect, but it is, for instance, metabolized on the liver. Of course, that those are some issues, mostly monetary issues, side effects as well. But the thing is that when that patient goes back to the community, is being followed up in the primary health care, again, with the medication reconciliation, can actually switch back to the regional medicine. So the overview of all of this is to emphasize the work of healthcare professionals, particularly pharmacists, to assist on using the best you can do actually from your medicines.
Can I add something about this medical? So if the really patients take so many medicine in the hospital, so the reducing of amount is only possible in the hospital, because in the hospital the patient is look after the doctor, pharmacist, how it goes, and we really have this patient. They stay for 1 week, sometimes 10 days, and the pharmacist and among with the doctors, they change. For example, the 3 tablets to 1 tablet, active ingredients, etc. So I wanted to add to his talk that it is also important that patient understand what is this medicine, that we adjust the background of the patient to the doctor adjust the information to the background of patient. This is another style when we talk to a patient who is clever, who knows everything, who check everything in GP chat, etc. And this is another situation if we talk to the patient who sometimes doesn't have many contacts with health providers, with the doctor or pharmacist. I met people with 90 years old who never were in any specialized doctor. They are just 90 and first time they are in the hospital. And they didn't know, for example, what we know MRI, or if the nurses is sometimes telling, oh, you need to undergo this and this procedure. They don't know what is this. So we always need to use a proper language, plain language, to explain what is going on, what would be with the patient. So this communication, this part of the staying in the hospital or outpatient clinic is very, very crucial.
Right. So Yolanta, my next question was actually to you. So how can we ensure that the patients are better engaged as partners in the healthcare systems?
I give you the example. I know from the statistic that 2030 we will have 1.6 billion people who are over 60 years old. So this is a big amount of people, and I think for these people we need also a special care and special engagement, because many times it happens this senior person is in the hospital, receives discharge. They even write in the medical information, he should be consulted by neurologist, she should be consulted by psychiatrist, but nobody did this follow-up. And when the family and the patient is not fully engaged, it could happen that many side effects and many risks happens at home, because these people went home and they forget how to take a medicine, which examination they should have next week or next month. So I think to engage in proper way patient and elderly patients and their families is very important. And it is also important that when we talk to patient, even an adult, we need to explain very carefully all information about side effect, what they can do if they receive any allergy or something like this, how to communicate this inspectorate for pharmaceutical agency or any other body or family doctor who prescribe the medicine, or this specialist who prescribe the medicine. So I think to the patient, if there is empowered to and involved in the process of treatment, if he is aware and receive a proper information, then we solve the situation in partnership with patient.
So my next question to you is to you, Christina. So what does safe care look like to patients with NCDs?
It's important implementation and clear qualitative standard, apply validate protocol in primary and community care, adapted for individual with chronic condition and cognitive impairment, measurable safety indicator, report rate of advanced event, adherence to medication protocol, monitoring of complication, active patient and family involvement in yes, caregiver in treatment decision and care planning to ensure risks and preferences are considered. External audit and accreditation demonstrate transparency and commitment through regular evaluation of safety practices.
Okay. So, Luis, coming down to you. So, healthcare workers don't work in silos. So, how can interprofessional practice contribute to patient safety in NCD management?
That's actually a very good question, because over the last few years, I've been seeing a development of specialties. Now we are actually able to detect and to diagnose in a more precise way. We have more medicines, more technology to use. We have actually more healthcare providers in a way that we have new areas of healthcare being involved, like dentistry, psychologists, physiotherapy. So what happens is that with all this involvement, unfortunately, there was not actually a system that provided a means of communication and access to information. What I mean by communication is that, of course, that the perfect world will be sitting on the same area or in the same building or even in the same room, but that's not the case. Actually, we see the landscape evolve in a way that people want to stay in the community. They want to interact differently with their GPs, with their doctors, especially doctors in hospitals, with their psychologists, with their physiotherapists. So the idea is actually to create a system where all the information is centralized. Well, first, to be able to all of those providers to write information that you don't have to share your side event or the adverse effect of your medicine with your pharmacist. You can, but why not with your dentistry? Or maybe with your nurse, or maybe with your GP, or even with your specialist doctor. The important fact is that that information should be saved in a way that other healthcare providers would get access. So the first point would be writing access to this information, or probably even before that, to centralize that information and to, of course, exchange information. It will be very tricky for me just to go through deeper in this one, because is that communication or just saving information? Yeah, maybe it's a bit of both. Maybe it's a starting point. But we do know that even when it comes to sharing information in the public sector or in the private sector or even in the social sector, that's not the case. We see a lot of providers that do the same exam over and over because the other providers do not know that that exam has been done, or some providers actually prescribe a medicine because they think that the patient is not under that medication, but is already been prescribed. So access to information, sharing information, actually the ability of that information be shared by the patient to any healthcare provider that he feel like they want to share that information with.
Good. So, Yolanta, my question is regarding incident reporting. So what do you think, what are the barriers that are there for incident reporting, and what could be done to improve the overall situation?
So one of thing is that our health system is still paternalistic, and many patients are afraid to tell the doctor about any side effects or report that something went wrong, that this tablet is, for example, very bad to swallow. You know, sometimes the tablets are so big and the patient is not telling the doctor the truth. I have problem. I don't take this medicine because it's not very suitable for me. So I think the patients are thinking, oh yes, if I will be complaining so much at the doctor, next time in future he will not accept me so easily. He will not like me as a patient, something like this. So this is one barrier. Another barrier that we don't have anonymous reporting system about adverse events or about something what is wrong at the communication between the patient and the doctor. But it slowly has changed. So this barrier were much stronger 10 years ago. Now it looks better, but still we have a lot to do to improve first communication, the second, the proper reporting, and the first thing, we really need to implement an anonymous style of reporting if something goes wrong. I think also patient should more improve their ability to be engaged in the treatment. And as patient organization, we should teach patients to be more empowered, to ask question, how to ask a question. If you go to the doctor, ask about this. And sometimes we have a list of questions to the doctor. It helps in the communication and also make these barriers not so strong.
Thank you. So now the house is open. If there are any questions from the audience, yes.
Hello, I'm Edwards from the UK. Really interesting comments. Thank you for the presentation and the answers you've given so far. I'm just interested, we're looking at patient safety, NCD management, and we've talked an awful lot about, thank you. We've talked a lot about adults. How does it differ for children? Because I'm an expert, we've heard today, I'm an expert in my Crohn's disease. I know everything about it. I can go in and have a really educated conversation with my consultants. But when it comes to my son, it's a whole different world. I don't know how to keep him safe.
So the question is...
how does it differ for children?
So you are right. With children, it's together. Okay. With children, it is absolutely different situation. And you are right. This is a really white table, which we need to fill with some guidelines and some instructions. Even in we have in Poland a special regulation, patient rights and spokesman, and this regulation has very nice points that if the child is to 16 years old, it is a full rights patient, and he should be consulted with all information about what is going on, that a doctor should explain everything. But this is theoretical, but in practice, this is always talking with the parents, with some caregiver, but not with the child. And it should really change. And I think slowly some campaign for patients' rights, for patient involvement, and it has changed. We have two pediatricians from my country. Maybe they can add how we as patient organization could work with in this topic, because it is really crucial. You know, I was young in communistic era, and it was that time that if a patient was term ill, very ill, nobody talked to the patient, oh, you are ill, maybe you die because you have cancer in the last stage or something like this. They didn't tell to the patients, but they talk with aunt, with other secretary at the department, you know. So it was everybody knew, not you. And same situation, it looks at children in the hospital. Everybody knows, but not the child. He is not involved. Sometimes it has changed, you know, at which children at diabetes. When children have diabetes 1, then they need to be really careful about their health. And then these children are have a lot of education, how to measure this level of sugar, glucose, and so they are very involved in the treatment. But I think also sometimes at cancer patient, so they have some therapeutic now lessons, and they know more about this disease, what could happen, how they should behave, how they should involve in the physical activity, which food they should eat. But this is only in the biggest hospital, in the best clinics. No, he has a different option. So
not only in bigger hospital. Yeah. I work as a pediatrician in small hospital, and we educated the children and family. And it is not in pediatrician side of my side. I must contact with moms or family, not with children, because take care about these children, take family, and I must teach family. I must take the authority as a doctor, and then I teach this, educate this whole family, and care this when they are sick.
Right. Yeah. So, Dr. Nikhil, you have some comment?
Yeah, thank you for this question. It's a very timely question. I don't know if you can see my background. We are celebrating, observing World Patient Safety Day this year. And that's not only 17th September. 17th September we launch it, but it's for a whole year. And the theme is on safe care for newborn and every child. So it's very much a relevant question. I won't go into the detailed technical discussion, for which we have pediatricians here, and they can reflect upon. But what we even Helen was involved in. So we have evolved these World Patient Safety Day goals. I will share the link here, but I don't. Not everybody is on Zoom, so Dr. Jaffrey, later on you can share it with the audience participants here. And when we were developing these goals, the first thing was, of course, the children are not small adults. They have their own requirements. And you cannot just, what you're doing for adults can just extrapolate to children. And that was very much peculiar, like say medication safety. calculation of doses in pediatrics becomes much more important than adults, and that's a cardinal kind of a principle, at least for giving medicines to newborn children. You have to calculate based on their weight and size. Similarly, like diagnostic safety, the child, they present their signs and symptoms very differently from adults, and sometimes they may not be able to communicate if they are very small, or even because of other reasons. They may have a fear to go to a hospital or having a bitter pill or something. So it becomes very important for service providers to be proactive and to adopt their practices according to the needs of the child. Patient engagement also becomes very important because for many of the reasons, still you will require their parents or whoever is with them to gather the information and to arrive to a diagnosis, or even later on follow up of their medications and care. And this is what we summarized in these World Patient Safety Day goals. Also, there are 5 goals. The first one is on patient and family engagement itself, and then we're talking about medication safety, diagnostic safety, infection prevention and control, and the 5th one on the care of sick newborn and small children. So very much a very relevant discourse, and I think we should talk about this very often. And we should have, what we are planning is at WHO level, we are planning some global workshops on implementing these goals, and certainly we will involve you also in some of the sessions, specifically on patient and family engagement, but also on other aspects also. Thank you. Over.
Thank you, Dr. Nikhil. So any other question? Okay. Good.
I have something to add, if you can hear me. I just wanted to add quickly to Nikhil's that the World Patients Alliance has a Bill of Rights for children and also for parents and caretakers about how children should be engaged and how parents should be engaged, because there are problems with both often. And the other thing we have is a short video on pediatric safety and the special problems faced by children. Thanks. That's all.
Thanks,
It's a shameless plug.
You're right.
Thank you. So I just wanted to continue conversation we had at lunch, and it's sort of re-emerged here at the panel discussion, is that patients actually live in the community. So I think the ultimate objective of health systems should be to make us spend least time we can in the hospitals, because this is the most risky environment to be at. However, I feel there is this, I don't know if I can call it ownership. The doctors feel they own the patient, the hospital pharmacists feel they own the patient, and community pharmacists also own the patient. So how through this sort of ownership we can collectively own the patient journey while patient owns his data and he owns his condition and all of that? And do we have any good examples of actually how we can make sure that all people involved in the care work around the patient rather than try to bring the patient to one of the silos, which they prefer or think it's a better equipped one? Thank you.
But anybody want to comment on this one? Yeah.
Yes, thank you. Thank you for the question. And the issue of ownership is very important. As mentioned, it's a very paternalistic system. And I think all of us, are very paternalistic if we don't realize that. This idea that the patient is at the center, it's relevant. I don't know, actually, I'm going to change it. I might have some ideas I want to share with you. How do we incentivize healthcare providers to support the patients? Because if you are in a hospital and you are incentivized to have your patient coming to your consultancy, for instance, that's a sort of incentive. Other incentive is if you have a support if your patient is controlled or if they are actually being assessed correctly with other healthcare professionals. This is a paradigm shift, of course. It probably will be challenging because we do have the facilities now. We have the clinics, we do have the hospitals out of the sudden, if you come with a different perspective, you actually have to change the landscape. But I think until we get at that point, I think it has to do a lot of the training and education of the healthcare providers. And yes, unfortunately, we are paternalistics, but we do our best.
Yeah.
Anyway.
I want
Yeah.
something.
Go ahead.
Okay. So one thing, I think it is a good future because, for example, cancer patient. Few years ago, he couldn't tell to the doctor, "Oh, I don't agree with your opinion. I will have another opinion from another doctor." Now it is possible, and nobody makes a big barrier in this. And there is also the continuum, which decide about different style of treatment for patients and engage patient fully. So I think this is a good step towards more engagement and more empowerment for patient.
So there was, yeah, okay, let's. Yeah.
Hello, it's a question for Dr. Gupka. It's about the strategy. As we heard from the last question, hospitals are no longer patient safety zones. Normally, they are risky zones. How the strategy addresses the hospital infections crisis? Is there any measures that can avoid the hospital infections to go into the communities and create problems there? Because we have a lot of elder people in Portugal that are afraid to go to the hospital because of that. Thank you.
So thank you for this question, and I think without any doubt, the hospital-acquired infection is one of the most prominent risk for patient safety, safe care, and certainly, as you said, in Portugal, but I would say all over the world, people sometimes fear to go to hospital because they may acquire some infection. Coming back to the Global Patient Safety Action Plan. So there is a specific strategy that is strategy 3.3 within the strategic objective 3 on clinical care. We are just focusing on the infection prevention and control. And then we are talking about more systemic interventions like having a national infection prevention and control program to very specific point of care interventions like hand hygiene and HAI surveillance. Apart from the Global Patient Safety Action Plan, recently WHO has released also a global IPC action plan also that is just focusing on the infection prevention and control strategy, both at the policy as well as at the point of care level. And all over the WHO system, we are trying our best to implement both the Global Patient Safety Action Plan and this IPC action plan also. Linkage to the community that I would like to hear from other experts also, but certainly I can more than agree with that. If we have high hospital-acquired infection rates around our community, people, of course, there is an access problem. People will not go to the hospital and will try to get the timely care because of the health-seeking behavior is altered, or there is a fear there. Certainly, there are two aspects. One is to certainly implement the IPC practices and reduce the HAI rates in the hospital. But I think there is also a community aspect to that, where we build more confidence and more trust in our healthcare system. That is both. Hospitals should project their image and should tell about what they are doing to reduce HAIs, as well as I think this is very much a job and a function of our community and our patient champions to build more trust in their healthcare system, both by educating the community and the patients, those who are seeking as well as also giving feedback to the healthcare facilities, how they can build trust and reduce also the healthcare associated infections. Kind of a small examples like say hand hygiene. Yeah, it's not only the health worker's responsibility. This is very much also the patient and family. They should be vigilant about, and they should be all kind of supporting that hand hygiene practices are practiced in the healthcare facility and of their own hand hygiene also, because that is also having very much importance. So this is what I can reflect on the question, but I invite other experts also if they wish to add on some other strategies, how we can build more confidence in the community, specifically on this aspect.
Thank you, Dr. Nikhil. So now I hand over the mic to Helen Haskell, the chair of the session, for her acknowledgement of our speaker and panelists, as well as her closing remarks. Over to you, Helen.
Okay, thank you. Thank you, Hussein. I'm going to be brief because I see we're really at time. So I'm just going to recap quickly. We've heard from Nikhil about global progress on the Patient Safety Action Plan, from Christina about the needs and care of older adults and the need for standardization and planning, monitoring, evaluation. From Luis about best practices in medication safety, need for an integrated system. And from Yolanta about care coordination and the importance of engaging with patients to involve them in the process to really partner with patients. In addition, we've had some very interesting, wide-ranging questions from the audience about many aspects of patient safety. So I'm just going to talk about a few key points that I would take away from this. The first is that whatever you're doing in healthcare, you can look to the Global Patient Safety Action Plan as your guide for patient safety, especially in the arena of patient engagement. Nikhil pointed out that the Global Patient Safety Report showed Europe as the most advanced region in patient engagement, but no one was actually advanced. Not one region had advanced to the point that they would be given a passing grade in school. So we've all still got a long way to go. Patient engagement, I think, is basic to good healthcare. It's the best starting point. It's the wedge for achieving good healthcare and patient safety. And organizations like those, like yours, like those that are in the WPA, are the force that can make this happen, because healthcare, as we just heard in that discussion about infection, healthcare establishment does not always have the will to make these changes from within. They need your help. The Global Patient Safety Action Plan provides a blueprint for all of this, from the patient encounter to international advocacy. So I urge you to go to the WHO site and download the plan and see if you can't help push Europe over the 70% mark. My second point is about something that we scarcely touched on, which is the role of technology. Do not underestimate the importance of technology in patient safety. Patient safety has been around for more than 25 years, and it has not progressed in the ways that we had hoped. Technology, if we use it wisely, has the ability to make the field of patient safety loose, to shake it loose, allow it to become what it should be. It can streamline processes, it can search for patterns, it can allow early intervention, facilitate diagnosis, detect errors, bring information to patients in a user-friendly way. But it also has unintended consequences, especially with the rapid technological change we're experiencing right now. And so patient safety systems, again, are our fail-safe there. They can have a large role in monitoring new technology. And third, what we've heard from all of our speakers and from our patient audience, patients with NCDs, especially older patients, need special consideration in terms of patient safety. They're often difficult to diagnose. They can go years without proper treatment. When they have treatment, it can be variable and complicated. It needs to be personalized. Not all treatments are safe for every patient. Patients often undergo, as Yolanta pointed out, multiple procedures, take multiple medications at a time, and the potential interactions are not always well known, even to researchers. We need evidence-based information for patients. We need to counsel vigilance and stress their role in improving our knowledge base by reporting side effects and adverse events to the national regulatory authorities. People need to know how to do this. And we need, above all, to be sure that patients understand they have agency over their own care. Because sometimes quality of life does not include optimizing treatment for every condition a person has. Patients need to learn to speak up, to explain their circumstances, their desires, and to work together with their healthcare providers to develop the best plan for them. And as you said, the current paternalism in our system works against that. Patients need to learn to speak up, to have providers learn to expect it. So if you convey one thing to the patients who work with you, I think that should be it. So that's the end of my lecture, and that's the end of our session. I'm now going to turn it over to Hussein for the next segment. Before doing so, I want to thank all of our speakers and all of our audience members for this great discussion. So, Hussein, I'm going to turn it over to you for the introduction of the Institute for Patient Safety and Research at the University of Kalisz in Poland. Thank you.
Thank you, Helen. Thanks a lot. So thanks everybody, our speaker. Thank you, Dr. Nickel. Thank you.